Start with Dr. Parikshit Gogate, a very experienced ophthalmologist, both in practice and also in teaching training, based out of Pune, to give the talk on where are we today, overview of the residency training program in India. So, yes, Dr. Parikshit.
So can you load my presentation? Dr. Ramadan sir, respected chairperson, an enthusiastic audience. Ma'am, this is some. So may I start, sir? This is a small talk on the overview of residency training in India. Well, traditionally, residency training in our country has been like the Gurukul system, in which the student serves, follows, observes, learns, and works for the Guru for 2 to 3 years, and that is how they gain knowledge. But today, teachers have to become facilitators of knowledge and wisdom. Because there have been studies from Hubli, studies from Pune, which we have done in H.V. Desai about 15 years ago, which showed that there is a great discrepancy in the actual number of surgeries performed by resident doctors and the perceptions of the numbers that are needed to master those. Phaco and non-cataract surgery teaching was neglected, and the residents wanted to be evaluated regularly, taught basic examination, use of equipment and procedures in grade 10. With this in mind, in 2014, the ARC, the Academic and Research Committee of AIOS, had started the READ study under Dr. Partha Biswas's leadership. This was to get a feedback from young ophthalmologists who had completed their training between 2004 to 12, who were 21st century trained, who were young enough to remember their training, but now experienced enough to understand what was the lacuna in that. Because when we ask residents, all the residents say, we want to have more surgery. But those who have gone out, been in the world for 10 years, when we ask them, what do you think was the lacuna? And we compared them with people who were 20th century trained between 1970 to 2000, to help AIOS frame guidelines for residency training. Well, now there is a huge difference in how India was 40 years ago and how India is today. Today we have 400 million children. Cataract is still a common cause of blindness, but earlier it was 80%, now it's just 50%. And the retinal diseases, glaucoma, they are becoming more important as corneal infections have reduced. So I will not go into the details, and the respondents, they were from all states, but if you will see, one of the difference that we see over here is, in the 21st century, there are more women who are there, who are being trained. Again, those who are second generation doctors or who are from a family of ophthalmologists have also increased. So that way it's becoming more familiar. And even today, almost 1/3 of residents took ophthalmology as their first choice or as a top choice for their career. So they are coming into this stream very willingly. Again, that way ophthalmology as a career is lucrative, there are no emergency hours, you can devote time to family and hobbies, but still there is a huge entry load for private practice. It's competitive and perhaps not that lucrative with NGO hospitals and charity. So when we looked at the rating of clinical skills that was taught during residency training, we found that refraction, the median is just 5.2, it's less than what it was for people who were trained 2 generations ago. For the rest of it, generally there is an improvement, because of course everybody now has a slit lamp, a pachymeter, a A-scan, B-scan, keratometry, arc laser. They are now not, something that is new in residency. When we look at skills for glaucoma diagnosis and management, again there is a huge improvement, because earlier there were hardly any applanation tonometers. Today, again, gonioscopy, applanation, pachymetry is there. But if you will look at, again, the median part of it, how they want to learn, things for OCT or gonioscopy, it is still not the perfect 9 or 10 that they would want. And one thing which showed is In the earlier cohort, people would do about 5 trabeculectomies before they pass out. Today, the average resident does, on a median, only 0 trabeculectomies. There is hardly any glaucoma surgery that is being taught in our residency training at this point of time. It has all gone into fellowship. So even we say glaucoma is the second leading cause of blindness, yet we have a case control study from Pune which has shown that even if a patient visited a doctor, an eye doctor, in the last 2 to 3 years, their glaucoma was missed. So a visit to an eye doctor was not protective for late detection of glaucoma. So glaucoma today even is a disease which is underdiagnosed but over-treated, and young ophthalmologists need to be made more confident in the training and the management of glaucoma. Similarly, for retina related skills, so we have our ARC chairman who is a very enthusiastic retinal surgeon. So again here, most of the retina related skills have become better in the last 20 years. Indirect ophthalmoscopy, 90D evaluation, OCTs, fundus photography. There was hardly any OCT before 2000, but fluorescein angiography. So it is much better when we are comparing it with the older cohort. But if we will look at in the developed countries in Europe or the US or Israel, there an OCT is a norm. It's like we do a direct ophthalmoscopy over here. That is still not happening in our residency training because still many medical colleges do not have this equipment. So there is a wide variation in the programs regarding retinal training. Most programs offer vitreous or retina surgeries only to fellows, not to their residents. And we know retinal diseases are a leading growing cause of visual impairment. The pre-millennium residents were never taught OCT or retinal lasers, but even for the post-millennial residents, it is still inadequate. And people would want to do a proper fellowship if they want to specialize retina. Comprehensive ophthalmologists as such are not being exposed to it. And I'm a pediatric ophthalmologist myself. When we look at skills for the children's eye care, and there are about 400 million children in India, that's almost 1/3 of our population. Again, perhaps in the 20th century, the median was much better as far as synoptophore, diplopia charting was concerned. And even then, strabismus surgery was not performed that much. Even today, in the residency training, hardly there are very few places where strabismus surgery is taught to the residents. It is something that they have to do after they pass out and they do a special fellowship. So again, for those 500 million children in India, there are just 500 odd pediatric ophthalmologists. And visual acuity assessments, amblyopia treatment, orthoptic evaluation is something all ophthalmologists must know if we are to address this problem. And again, for the deaf mute, the learning disabled, the autistic, the physically challenged, there is hardly anything. And finally, if we look at the surgeries performed independently during residency training, then yes, in the last century, the most common surgery was intracapsular cataract extraction. Today now, it has become manual small incision cataract surgery, followed by phacoemulsification. Again here, the mean is quite big because there is a huge variation. If we look at the median, then 50% of the residency training programs in India give one or less phacoemulsification during the training program. So the variation is huge. And if you will see, other than pterygium and chalazion, all the other surgeries, the median is almost 0 for even things like DCR, retinal detachment, vitrectomy, keratoplasties. This is something that a resident is not being exposed to during their residency. We also ask them about their taught academic program. So here again, they like a lot for wet labs, but which were not much. Now this has changed thanks to AIOS. There is now SSTC, TSTC, DSTC, and in the last 7 or 8 years, there has been a huge change, and we are moving towards wet lab and simulation. The IOS headquarters now has a cataract surgery simulator. So yes, a lot of new things have happened after this study has taken place. Again, if we look at the dissertations that these students were given, one good thing is that a lot of the dissertations have been presented at local and state level, but that's still just 1/3 of it. And a lot of them have been presented by the students themselves, not the teachers. But again, if we look at the national and the international level, it's still very, very less, just about 7% or so. And I think that too also from residents who have been taught in say AIMS or LVP or PGI, only because they are only getting to do that kind of research, or Arvind. And in the rest of them, well, there is not much to show about. So the strengths of Indian ophthalmology is still a sought after career. There are more second generation doctors choosing ophthalmology. Almost all clinical skills, teaching and exposure to investigation has improved over the past decade. Exposure to cataract surgery is adequate but not uniform. And manual small incision cataract surgery is still the commonest surgery that is taught today. There are many more women in ophthalmology that we just have to walk out and see. But the weakness is there is a geographic imbalance. Just 5 states of India, and they are all southern states, Maharashtra, Karnataka, Tamil Nadu, Andhra with UP and Delhi, have half of India's ophthalmologists. Journal clubs and wet labs were being underutilized. This is changed now. Simulators are there. But non-cataract surgery is still not being adequately taught. Midterm assessments are rare. And exit exams are mainly theoretical and practical exams inadequate. There have been residents who have not done a single surgery, but they are still master of surgery at the end of their term, and they have a certificate to show that. In some countries, we have pre-entry assessments like binocular visual acuity assessment before you are going into a surgical line. That is still a long way ahead. Yes, we have institutes of excellence. There is Arvind, there is LV, there is AIMS, there is SN. But again, in many ways, they are an oasis, and it's not an evergreen forest. And AIOS is doing its own bit to change that by having young ophthalmologists being taught more and more skills. And I think we still need to do a lot of that more. So this huge variation that is there in teaching, clinical, surgical and academic, all of them, well, this has to be standardized. We need a structured residency program. Today, it's all cataract focused. Cataract is important. A lot of us earn our bread and butter and perhaps jam by doing that. But then there is still more to ophthalmology than that. And we should focus not on what is taught, but what the student learns. Just one last one. All this was the student's perspective. There is also a teacher's perspective that we have taken. And again, in this teacher's perspective, teachers agreed that we need to improve the clinical skills much more. And again, surgeries need to be performed more, but they are not able to do that because they have too many residents, and there is also an emphasis on quality. So last I would like to conclude is, when we are having new residents, when we want new ophthalmologists, it's not just their heads or their hands, but also their heart. They have to be compassionate. And well, AIOS is doing a lot for improving residency training, but we still need to do a lot more. Thank you. Thank you for giving me this.